folks of the Learning Gender Surgery online forum. This is Vadivu from Vellore. It's a pleasure and honor to be hosting Dr. Georg Auzinger this evening for a light-hearted conversation. Dr. Georg Auzinger is a consultant and reader in intensive care medicine at the King's College Hospital. He's currently the director of the ECMO services at the King's College Hospital and chair of critical care at the Cleveland Clinic in London. He has special interests in ECMO, acute liver failure, liver transplantation, ARDS management, fungal infections, and transesophageal echocardiography in critical care, and is published widely in these topics. A teacher par excellence, he is widely loved for the precision with which he delivers the finer aspects of critical care. So welcome, Dr. Georg Auzinger. How are you?
Thank you for the invite, Vadivu. It didn't sound like you were talking about me there just now. Must have been another person.
So that was very formal.
And opposite me sits, one of the best, I can't call you trainee doctors, non-consultant grade doctors we've ever had at King's. Hardworking and diligent and very, very knowledgeable.
Thank you. So tell us about your early medical schooling.
I can't remember. It's been so long ago. So look, I'm originally from Austria, you know that, and I went to medical school in Innsbruck, which is a nice little town in the mountains. And I spent 6 years there. And how did I get to medicine? Well, a little bit like many things in life, I guess, by chance. So I took up one of these, and I'm sure you do these things as well. It's certainly also something which is quite common in the UK, that whilst you are in the final years at school, you may do a kind of attachment in various workplaces to help you decide on which career path to pursue. So I in fact ended up getting 2 jobs in 2 consecutive years in a hospital as a theatre porter. Right, so that was at the age of 16, 17. And it was very nice actually, because everybody was very kind and helpful, and I was allowed to watch surgical interventions. So it was orthopedics and urology, funnily enough, not 2 specialties you would normally associate as using the same theatre complex, but they were in the same building, and they were adjacent to each other. So there were a few orthopedic theatres and urology, but I sort of spent quite a lot of time watching orthopedic interventions, hip replacements, knee replacements, arthroscopy and the likes, and I quite took a liking to the hospital in general, the atmosphere, the people you got in contact with, also the patients, because obviously they were awake when you brought them to theatres, and that's really how I got into medicine. So a type of apprenticeship, if you want, and maybe seeing the hospital in a slightly different way than doctors, once they've finished their training, do as a non-doctor. So that's really how I decided I wanted to do medicine, and ended up in Innsbruck, and I finished my studies. And initially, in fact, I was planning to go to South Africa, and I had a job lined up for a year. At the time, it was still apartheid, So it would have been in a non-white hospital, but for all sorts of reasons, it unfortunately, I have to admit now, didn't happen. But in a way, it's kind of, I guess, the destiny side of things that, you know, I probably wouldn't ever have ended up where I am now, for good or for bad. So I then instead ended up working a little bit, and working is probably the wrong terminology. I was like a visiting doctor with no practical experience, and I did spend some time in Italy, in Milan, and that again was in theatres with anesthetists in an emergency theatre. And then I started training in Austria, in Salzburg. That is my hometown. And after some rotations through surgery and medicine, I decided to do medicine. And I don't know how training in India is, but in Austria it's very different to the UK. You usually don't rotate through various different hospitals. You start in a place, and it's not uncommon, or used to be not uncommon, that you potentially stayed in the same place for life. So I was in a relatively small hospital, but I guess the advantage of that was that due to the lack of specialty services, and I guess, you know, a lot of the specialty services like nowadays, and in DGH type hospitals, DGH meaning district general hospitals, did not exist. So for somebody who did general internal medicine, you had to cover everything. So, you know, you did cardiology training, but we didn't have a cath lab, but, you know, from echo service, so all the non-invasive cardiology, up to pacemaker insertions, and gastro, the whole palette of endoscopy, that is upper GI and lower, without necessarily having all the interventional expertise, because varicose bleeding was a rarity. Although I do still remember, you know, it was the time when varices were injected, and I do vividly remember having first used, it was called the 6-shooter, I think. It was this style band rubber thing which came onto the market. That was back in 1993 or 4, I think. And we've also had a fairly small, you probably can't call it intensive care unit. It was more post-operative recovery, plus there were also 4 monitored beds for medical patients, in-house cardiac arrests if they survived. And I do remember that once I had a patient, an elderly lady who had heart block, and our intensive care unit, as I said, not staffed by intensivists back then, and the anesthetist helped out every now and so often on the medical side, but this lady went into renal failure, and nobody's ever done hemofiltration in the hospital. So I remember that with the anesthetic head of service, who had come from a large university teaching hospital, we've set up hemofiltration for this lady, and she did survive. And, you know, it was like lots of interventions, see one, do one, teach one, I can't say, because there wasn't really anybody around, but I sort of got introduced and more interested in the acute side of medicine, and putting in PA catheters, and then also on the ventilation front whenever that happened, which was quite rare. And I sort of never really had plans to stay put. and I applied for a job in a Lancet advert, fairly naively at the time, but that was in Melbourne, in one of the largest intensive care units in the country. And unbeknowingly to me at the time, they were really struggling to get any trainees. So back then in the early 90s, mid 90s, nobody wanted to do intensive care as a career. So they were relying solely on international recruits, or by and large. So I to my surprise, got a job offer for a 1-year placement. And that's how I ended up at the Alfred Hospital in Melbourne. And yeah, I had a great time there. So, you know, I've spent in total almost 3 years there, and got exposure to, I guess, the entire breadth of ICU. It's a large tertiary institution, the Burn Center, the only at the time level 1 trauma center in the state, a very large heart lung transplant program, so a lot of tertiary, quaternary cardiac stuff. And the only thing there was anything to do with livers, because the liver transplant place in Melbourne is at the Austin Hospital. So ironically, during my training, I didn't really have a lot of exposure to tertiary liver intensive care medicine, but pretty much everything else. And it was sort of then really a decision after 2.5, 3 years, which had to be made. Do I stay in Australia, or do I come back to not necessarily Austria, but Europe? And that's how I ended up in the UK, really. And after a very brief spell at St Thomas's Hospital, I then started at King's College Hospital, where I still work. And that is now more than 20 years ago.
So it was in the year 2000 you were appointed as consultant in King's College.
Yes, I was initially a locum consultant, it's called. So I didn't have a permanent position. And that at the time had to do with funding arrangements. And my then peer, I call her, Professor Wenden, had been running the liver intensive care unit, which was part of the Institute of Liver Studies and part of hepatology and liver transplant services, was completely separate from critical care. And that remained the case for, well, more than a decade after I joined. Obviously now it's all different, but at the time it was separate, although after a couple of years, and because my background was pretty much in non-specialist liver ICU, but all the other stuff, I started rotating for a period of time on a 6-monthly basis to general ICU as well, which at the time was, well, you know, Jack Steinberg ICU. That was the only other ICU that was at King's. It had happened initially, I was at St Thomas's Hospital, and in 1999, there was a big change that happened, you know, in as much as 2 institutions merged. And that's always and often a very tricky situation. So the then separate institutions of Guy's Hospital and St Thomas's Hospital merged around 1999. The intensive care units merged, and Guy's had a very reputable and well-known ICU, as did St Thomas's. The Guy's ICU at the time had been run by David Bihari, Professor Bihari. He since left and is now in Australia. And St Thomas's ICU had been made quite famous through Professor Bradley, Ron Bradley, who's probably the founder of the right heart catheter. So he described inserting a catheter into the pulmonary artery and measuring cardiac output in the late 60s or early 70s, and before Swan and Ganz then developed the balloon tip, and they patented it. But the original idea was from Ron Bradley. And that was the then called Mead ICU, and David Treacher was then the director of the unit. But it was quite tumultuous times because of two of these institutions with considerable, as you can imagine, egos coming together and a bit of a power struggle. So I came there probably not at the best of times and did apply for a consultant job, but didn't even get shortlisted back then. I mean, I now understand why, but and that is how I then ended up at King's, because Professor Wendon was looking for a colleague, and that was originally for liver ICU, but then ended up to be a joint post in 2002. Although I stopped rotating up until really I took up the clinical director post for critical care at King's. I stopped rotating to general ITU back, I think, in 2006. So from 2007 until 2013-14, I did solely liver ICU.
So from being a general intensivist to becoming a liver intensivist, how was the transition? Because you said you didn't have any liver transplant experience. No, experience, it's about a desire to do things. So did you feel like you were pulled off from what you liked doing to a new area just because they needed someone to run the department?
Well, look, somebody once told me, and it's probably true, liver intensive care is just intensive care with yellow people. So, you know, there is no big difference, is there really? Look, at the time, I again was probably fairly naive around the politics, and yes, obviously you get tested out by lots of people, and looking back now, clearly that was also the case, and some of them may have not thought very highly initially of me, but you know, it I guess was through hard work and just being omnipresent, and at the time also Jules was very busy. She not only obviously did cover and had been covering clinically for 10 years plus on her own, with some weekend respite by senior trainees whenever she had one, or by some of her hepatology colleagues to nominally cover. But, you know, she became increasingly, I think, sought after in the world of intensive care medicine as also liver critical care. You know, it's a relatively young specialty. If you look back now, in the early 2000s, there was no such thing apart from King's, like liver critical care, or even a specialty area within the societies. And, you know, again, intensive care training is fairly young. So when I started in the UK, that there wasn't a faculty of intensive care medicine. It was all under the Royal College of Anaesthetists, whereas now there is and has been further on a joint faculty, and now Intensive Care Society and the Faculty of Intensive Care Medicine is a separate entity. But there was no formalized training apart from being attached to ICU and doing your time. It's all very different now, obviously, and the same can be said, or even more so, for a subspecialty area within ICU, that is liver critical care, which sort of started really becoming also internationally more recognized, and clearly Jules was on the forefront of all of this, so invited a lot and going to lots of conferences, and then also taking up increasingly managerial positions, which then in 2010 or 11 ended up as a really merger of all ICUs and her becoming, before I was the clinical director for critical care. I think that was back in 2010. So going back to your question, I guess, I did a lot of clinical work. I was present a lot, and, you sort of introduce certain concepts which maybe from a liver perspective, people were more alien to and didn't used to think of a lot or be familiar with. So I guess you sort of cross-pollinate and cross-fertilize and end up with the best of both worlds. So I think, having this close collaboration of somebody who's come from a completely different background, which is hepatology, with somebody else, although I did medicine primarily initially, but then full-time ICU, was probably a very good combination. And, I've obviously learned a lot during the times and in the first few years, and I've never stopped learning. This is an ongoing process.
So, as a clinician, what would you consider as your major contribution to liver critical care?
Look, I think my biggest contribution to all of this was once I was in a position to be a decision maker, to choose the right colleagues. I don't think there is anything else I would put forward as being as important as that. And you've met all of them, and I think it's a brilliant group of people, and with lots of different skills and expertise and interests, and a very close-knit team. And I think that's what makes it so strong. And I think in a way also the collaborative aspect with the non-critical care side of the service. And yes, I guess, I probably have contributed to that in a way, in as much as I think I'm getting on relatively well with most people, and try and foster a working together. And clearly also then in my more higher managerial roles and as clinical director for a different department, trying to maintain the genuine interests of liver ICU as a specialty. I think that's also something which is probably quite important, because one of the dangers always is when you're merging areas that you lose the identity. So trying to maintain what is so special around this place. I think I've spent quite a lot of time in my more recent stages of my career in trying to make sure that we are not throwing out the baby with the bathwater, because clearly, there may be other people who feel very differently to that and say, well, it should be fully part of ICU, which managerially it is, but I think there is something which needs preserving. And, you've probably made other people think in the same way. And certainly my successors, I think, have continued trying to foster that and do that.
ICU as yet. In my understanding, you've brought in a fresh way of looking at sick liver patients, like from an all-organ perspective rather than going from liver to other organs. So I think that is very important. That's very important change over years, and I think that change should have come with you, or I may be wrong. So,
do you know what? I don't necessarily think that's true. So, I've in a sense, I think I've sort of followed in the footsteps of my peer at the time, and I think she's been very influential to whatever I've done since. Have I contributed and brought new things into the thinking of the place? Well, maybe yes, but I wouldn't want to overrate that. But it's quite correct what you say, and I think that specialty areas always can learn from a more generic approach and vice versa. So I think what makes the place very strong is that there is this coming together. And you know, you've probably seen, for me, the best example always is the sickest of the sick. And let's say, you know, the patients who need extracorporeal support, and we support them on an ECMO machine, for example, and you've seen quite a few of those cases through transplantation. And one of the strengths in general of I always thought a place like King's is that you have got all the specialties under one roof, and it's not like a PSML service where one group of people only does one thing and the other one does something different. You need to try and amalgamate the best of what you've got, and I think that is what ultimately makes it strong. The reason why I'm bringing ECMO up here is because you sort of realize that when you go to conferences and present data, that, you know, the big strength is that you have got a group of like-minded people who are not super specialists just in one area, but can deal with the patient much more holistically and every problem there is. That's also what I always would underscore as one of the differences, good or bad, between maybe really high quality UK or Australian, I'm saying here, intensive care provision to the States, for example, where, as you probably know, a lot of the services are run by different specialties. So if you've got somebody on the ICU, the nephrologists would look after the kidneys predominantly. Respiratory physicians would come in and deal with, in tandem with the respiratory therapist, the ventilator and the lungs, and the intensivist is sort of somewhere in the middle. Maybe a bit unfair, and I'm sure there are nuances and differences between various places, but I think places that do really work well is where all of that is integrated, and you know, people can join forces and do everything in a very comprehensive way.
So coming to the next aspect of what you mentioned earlier, it's about mentoring. So there are different levels of people that you've mentored, but for me, I was very much impressed with the advanced critical care practitioners. And I learned that you are one of their prominent mentors. Um, so this is something, advanced medical care practitioners for the Indian medical colleagues. So these are nurses and technicians who take up an advanced course to practice medical care. Something like this came up earlier in India, I think two years or 3 years back. They introduced a concept called bridge course, where the allied healthcare workers in medical training, they can take up different specialties and they can start assisting doctors. But when this idea came up, we were not very happy as medical doctors. There are many reasons why we were not happy, because there are a lot of quality control issues that will come up in our setup, because it's a very large country, so there'll be a lot of administrative problems. But one factor that I always thought was uh, we still practice meritocratic hierarchy. So as doctors, we are still not open to nurses and other technicians becoming doctors. So that way, I was very much impressed with the advanced critical care practitioners in UK, especially at King's College Hospital. I have many friends amongst them. So tell us about your experience in mentoring ACCPs. I'm not sure if you are one of the
So look,
brainchild.
firstly, I'd need to stress that it's not a service which I've introduced. So that was done before I even got into my administrative and director post for critical care. So it's Tom Hurst really, who is one of my colleagues and trauma and ICU consultant and the lead for neurocritical care. He used to be. He's now the director of HEMS, actually, the helicopter emergency service in London. So I think what you have to also appreciate is that there are clearly lots of differences between healthcare systems and your system in India and the UK and the States or Europe. And a very pragmatic reason, obviously, behind ACCPs or physician assistants, which are very commonplace in the States, for example. And some of them also are based in the ICU and in emergency medicine, is manpower, right? We have got an eternal struggle in terms of recruiting enough doctors. And it will get even worse, obviously, now politically with what has happened in the UK prior to COVID, where lots of doctors used to come from Europe, like myself. And clearly in the more recent past, yes, from India and other places. So there's a chronic shortage of doctors. And one of the ways, obviously, of dealing with that is to think creatively about certain aspects of what we used to always associate with, well, that's a purely medical activity. You know, how could that potentially be taken on by other members of the multidisciplinary team? And let's face it, a lot of what we do is task orientated. And think about, you know, in theaters in lots of countries, although we've got something similar here in the UK, which is the ODP, but, you know, in the States and also on the continent, you've got lots of anesthetic nurses. So they would do a large part of the anesthesia, often overseen by a consultant, but would work pretty independently and deliver anesthesia. And likewise, you know, you could go even as far as ECMO, for example. There's no reason why a paramedic could not cannulate, you know, for ECPR if that were ever to become something more routine out and about for out of hospital cardiac arrest. So, you know, there are task focused and orientated technical skills which anybody can learn and be taught. And in fact, you know, often for us doctors, as we are growing older or ending up doing more managerial tasks and maybe less clinical time, you know, there is actually people who probably do it better than we are, right? If you ask me nowadays to put a small cannula in, I may struggle, you know, I may be able to put an ECMO cannula in, but not an inflon. So it's for things which do require routine and daily practice and doing it all the time. And you know, for the ACCPs, I'm not saying that they're only technicians, but you know, they also within their training, and that's testament, I guess, to all the doctors, consultants who've been so supportive of the program, that they've been taught very well, both at university, but then also during their clinical attachments. And they are really phenomenal members of the team, and we probably couldn't do without them anymore. And equally, I think, you know, it's a two-way process, because you always also make maybe certain posts which, in terms of career progression, may be difficult. And you know, I don't know how the situation in India is, but in the UK certainly from a nursing perspective, you end up at the highest level, but then everybody is trying to go into management jobs, which is a great shame, because the most experienced and senior nurses and matrons end up not being there anymore to provide clinical care. So for some of them also, it is a means of trying to do something completely different and maybe still keep them within where they are really a hugely important resource, that is clinical medicine, rather than have them all drift out into middle management. And I guess one of the problems, obviously, we do have in terms of funding of healthcare, and as compared to the States, that the pay for nurses is very, very poor. You know, if you compare it to doctors or consultants, the nursing pay is clearly a lot less than, for example, in the States, where, you know, nurses are generally speaking paid very well. And I presume in India it is not too dissimilar, right? Yet, you know, the nursing staff often are very, very skilled group of people, you know.
That was really an eye-opener, the way you put it. So about mentoring the medical doctors and your colleagues. Wow. So what are the challenges of a teacher?
I'm being evasive here now. I think, you know, the challenge is from a very pragmatic perspective, and now for me is time. And it used to be very, very different. So, you know, I really took great pleasure in teaching and spending a lot of time on the ward rounds doing just that, which you know, sadly in many ways, I just don't have time for anymore. It's such an important part of what one does, and in a way also sad, because yes, that is what maybe people remember when they were at the receiving end, so to speak, the good mentors they had. And, you know, we're saying I used to do lots of medical student teaching at the bedside as well, but all of that has fallen by the wayside also because medical students training has changed, and it's not based on so much teams anymore, and it's a very different syllabus and curriculum now, with blocks of activities, and, you know, people are not attached anymore to a firm, if it were, and they just do their blocks, they get their signatures. I mean, you know, that there are people who want to learn and who are really enthusiastic and engaged, but I think generally speaking, these changes in training are not always to the better of the profession and for the trainees. So I feel sometimes sorry for them. In terms of mentoring in general, I guess it's a personality question as much as anything else, and realization that you can't always be there and try and in a way oversee everything and make sure everything's perfect, and you want to leave a legacy. And I think somebody said this once to me, and I think this is very, very true. A great leader is somebody that accepts and has got insight in his weaknesses, and who's able to let other people grow and able to leave a legacy. So, you know, the best leaders are the ones, and that's very difficult actually. If you think about it, maybe in ICU and critical care medicine a little bit easier, because we are such a team-orientated specialty. But if you think about other specialties which are very much ego-driven, and you know, this is not meant critically, I think it's just the way it is. If you want to be a top surgeon, you learn during your career to use your elbows and get to where you are, not only through your potentially superb skills, but also because of ego and being able to push others aside. So for surgeons, I think this is a lot more difficult than it is for such a team-based specialty as is critical care. And you've probably seen this. We all realize we couldn't do without the rest of the team. If you've just had the consultant there, well, who's setting up the filters, washing the patients, making sure there are no pressure sores, making sure there are no medication errors, monitoring, recording, documenting. So in a way, I think it's easier for us, but yet still, I think that the realization that you are only as good as the weakest member of the team, and that's become very clear, I think, during the last 6-7 weeks and a pandemic situation where you have to work under very different circumstances and where everything is much less than ideal. Yet, I think the major point to make here, and as I've said at the outset, is that you need to realize that the best legacy you can leave behind is to let others grow, learn from them. I'm learning every day from my colleagues. At times they annoy me a great deal, but then I think to myself, brilliant, and obviously they are trying to make their mark and try to impress, and they're all very ambitious, and that needs to be supported, and they can teach you things. I've changed the way I do medicine and think about what is possible, and we often joke about that, and did joke about that, but the truth is that you do learn a lot from your younger peers.
So my next question was, you answered my questions even before I could ask them. So this is the reason why you are idolized by, not just loved, you're idolized by many nurses, junior doctors, and
who is that? Give me some names.
Most of them. I may be the last in the list, but yeah, most of them. I mean, I should say almost every, and you said it, whatever we've seen in the last 2 years, you said it, that you are more of a learner, and by being a learner, you by default become a teacher as well. So as you were answering the question, you were also talking about leadership, that an ideal leader has to be a mentor, someone who mentors choicelessly. So, how will you describe yourself as a leader? Would you put yourself as a top-down leader? No, I know you're not.
Look,
you are someone. Yeah.
I don't see myself as a leader, full stop. I mean, some other people may feel differently, and it's very kind of what you've been saying, that being idolized. I don't see it that way, and sometimes increasingly I think more that I'm failing just because maybe there's too many plates spinning, and as I've told you in the past, I'm not a woman. I can't multitask. So that's obviously a gender problem here, but I can't remember now what question you asked, actually.
Because I didn't complete my question. So I was asking if you're a top-down leader, or
yes.
Step back from within.
No, as I said, I don't consider myself as a true leader anyway, or a poor one, and clearly not top-down, and in many ways very much reactive. I need time to think and process things rather than spot immediately what the problem is and come up with solutions and be very proactive. That's probably one of my big weaknesses. So I'm a more, if you want, introvert, analytic type personality, rather than gung-ho and coming up with very bright ideas. That is probably one of my significant weaknesses. From a leader perspective, and I guess you learn from experiences around you, and you see certain things where you think to yourself, that's not how I want to be or perceive to be. Maybe a lot of it is also about perception. You know, you act in a way that you think will work and may make you look good. So there is the personal vanity aspect of all of it as well. But I think the only way, and especially with a large team, to get anywhere, and let's not forget, for example, for critical care, and during my tenure, which was only 3.5 years, but the size of the department has increased dramatically. So, you know, you're ending up with 45 colleagues. And, you know, there's always difficulties because you will have individuals who are more of the disruptive type and critical type. But I think the only way of keeping a department together, in a sense, is by working together and making things happen by consensus. You know, there is no dictatorship, and certainly not in the NHS. The NHS is, in that sense, a very socialist, if not communist system, right? It's you can't, that's a thing of the past, where you had the top guy telling everybody what to do. You know, people will just not tolerate that, and you will not get anywhere, and that is where the department as such suffers. So I think very much what you need to tell yourself on a regular basis is that the ego, when you're responsible for a large department and many people, needs to really be well in the background, and the only way of getting somewhere is by consensus and making sure that everybody's pulling on the same string and agreeing with you and working together with you.
So when we colleagues used to have a chat amongst us, I always used to tell them that you're an iconoclast type of leader. Yeah, it's a gossip. So iconoclast type of leader means someone who works with single-minded passion for their work, and by default they inspire the team. But everyone else used to describe you as a nurturer, you know, someone who consciously comes out as a mentor and cares deeply for the success of the juniors, and you know, things like that. That looks like, from what you're saying, I was right. At least for once, I was right. You you have been yourself, and by default, you started inspiring people around you because you're extremely popular among. You may not like this, me saying this again and again, but even for me, it was a shock because I've worked in several places. I've seen very few people who are extremely popular among the team, but they're not. They won't be loved by everyone. But you're someone who's very popular, and you have so many admirers, and people just love you, and that kind of even kind of troubled me because, you know, uh, troubled me in a sense from my political perspective. I was not used to, you know, everyone admiring one person. I was not used to that kind of thing. But yes, people did that. Um, I don't know how you would
I don't know
explain
what
that.
to. I don't know. I don't know what to say to that. I don't. You know, I'm not entirely sure if that's really true. I think, you know, I've got few enemies. Let's put it that way. You know, and that's probably equally important. And yes, you know, you need to try, and you don't need to be friends with everybody, but you need to try and work together with people. What's gone amiss, and you know, that is a bit of a shame of late, is just, you know, this mentoring aspect. Although again, in my clinical director days, maybe I had the opportunity to possibly mentor quite a lot of the younger colleagues and consultants, and before they became consultants, and then through, you know, these appraisal processes we have to do. So I learned a lot about my colleagues because I used to appraise, well, a half, if not 2/3 of the department, and I found that very helpful. But certainly what has gone astray of late is the true mentoring and teaching So it's maybe happening on a different level, but not so much in the classical way of what I like doing in the past and had much more time to do, which is at the bedside.
You have mentors like that, like how people perceive you, like a personal mentor. Did you have personal mentors like that?
Look, I'm always, like many other people, I guess, quite critical of what we do in the NHS in terms of all the, if you want, bureaucratic hurdles. I shouldn't call it that, but you know, the appraisal, the revalidation process. I mean, the difficulty is, you know, it's very easy to say this is all nonsense and a waste of time, which, you know, I think for many aspects of it, that is true. And you've gone through some of the training everybody needs to do, and the leap training, and you know, that's probably pretty foreign to where you are now. But the appraisal as such, and I've sort of maybe turned 180 degrees, is a valuable process if people do it well, and if you choose a person who can act as your mentor. So, you know, and that doesn't need to be somebody who comes from within your own specialty. To the contrary, I think it's sometimes actually better if it's somebody who doesn't really know your subject matter, and maybe a wise person though, or very clever person who works in a completely different area. So hence, you know, my more recent appraisals I've been doing with people who are not within critical care, right? So yes, I think some of them do act as mentors as well, but clearly, you know, it's still up until today, although unfortunately we don't meet as much as we did in the past. It's Jules. So, you know, she would be somebody I would usually consult if there is something I just can't get my head over.
Wonderful. So how do you plan your day, George?
Very poorly. That's the only answer I can give. Lastminute.com, right? I'm very poorly organized, and that's why I need a PA.
Well, you are someone who comes so early. I think you turn up to the workplace ahead of everybody else, I think.
Well,
I
you
do
know,
come earlier than you at times.
Yeah, that's right, yes, which was a constant concern to me, and left later than I did. Well, do you know what? I sometimes admire some of my colleagues, and I won't name any names, but you know, there are people who are probably as effective as I am, but spend much less time in the hospital. So it's not necessarily the time you spend there, it's also the productivity resulting from your time spending. And so, you know, not all what I'm doing is very productive, I have to say, and that's probably more because of the too many plates spinning. You know, I'm not very good in finishing, let's put it that way. It's one of my weaknesses. So I escape into things I want to do rather than the ones I have to do.
So then you've actually come to the next question. So yes, you know I'm a feminist. What you don't know is I'm an empath as well. So I've always thought, you know, men, professional men, the leaders who are very popular in the profession, their contribution to the family is undervalued. I do know they contribute a lot because my father used to be one thing. But how do you balance your work and family responsibilities?
Well, it's very simple, very badly. Look, nobody can convince me or tell me that you can be perfect in all of these areas, and something always has to give. I've got it in a way easier, or that is, the choice we or I have made, in as much as you probably know my personal circumstances, that it's a long distance family relationship. So, and obviously it becomes very obvious now that this is actually quite difficult to juggle, because I haven't seen my family for 2.5 months. I'm gonna start crying now in a moment. But in a way, it's worked as a compartmentalized system. So I took my time off and spent then, or tried to spend as much time as I possibly could for blocks of time with the family who lives in a different country. So and then at the same time, I've got the luxury of, when I'm in the UK and in London, to not needing to dedicate a lot of time to family chores because I'm on my own. So in a sense, that's an easy get out and escape. But clearly, as one can imagine, in the current situation, I've got no idea how. I've just booked a flight and I'm going to stay for 2.5 weeks, because I've got no idea how travel will evolve. What seemed to be so easy and straightforward, and obviously, yes, I've got the luxury of being financially fairly independent. I could go every second weekend potentially and spend time with the family, which obviously now I can't. And airlines going bust, and it may also, from a financial perspective, become very difficult. And clearly, once I really start working clinically, as well as you've said, in an administrative role, leading a service in a different hospital, the liberties in terms of time taking out may change. So that's my personal situation, but I think for everybody it is very similar, and especially if you've got children, and especially for women, I think so much more difficult than for men in our societies. And look, I'm guilty as charged, and nobody really sees childcare as something particularly difficult to do. But, well, once you have spent a few days alone with a child, because your partner is not around, you do see that it's a fairly tough job. That I've tried to do this, to do some work and meetings aside of looking after a child, but that's very tough going. So I've only got admiration for women who manage to do both, who are work and doing really highly complex and strenuous work, and then they go home and they may need to look after the children. I think it's very, very difficult, and especially if somebody then, like many of us, and especially if we're working at the forefront and in very highly specialist areas, also wants to do some academia and maybe teach, and all of these things we've talked about, I think it's impossible to do.
Sorry, that was an unpleasant question.
No, that's all right. Look,
Yes.
but it sort of shows that, yes, it's easy for me to say, because I'm here on my own, so I'm probably a bad dad. I'm trying to call and FaceTime and all of this, but that's a poor substitute of spending time together. So yes, these are really exceptional circumstances, but even for people who live in the same country, or see each other every day, trying to be perfect in all aspects of it, and especially for women, I think is very, very difficult.
So that's it. I don't have any more questions. It was great. Anyways, I had all these questions sincerely in my mind, and I'm very much certain these are the questions that all younger doctors would be having. I'm just assuming, and you answered all of them very well. um, I mean, that's a cliche if I'm going to say that it was very good, but anyways, I have to say, I can only say that much. Um, I, I'm certain this would have benefited the viewers. Um, this would, your answers would put things in perspective for them if they're struggling with any one of the issues that we spoke earlier. Thank you so much.
Well, thank you, Madhivu, and thanks for the lovely time having spent together, and all your valuable help. It was brilliant, and hope to see you again soon in person. And for young people, if that was in any way helpful, I would say, even after having been in medicine now for 30 years as a doctor, I still take great pleasure in doing it. It's a vocation after all, and I'd probably be really crap in anything else, so it's probably the only thing I can do by now. But look, I really love what I do, and I hope that that is something I can inspire people with around me, and I wish everybody best of luck.